Hi guys, welcome into CRNA Case Files, where I teach you to think like a CRNA, one case at a time. In today's video, we're going to be discussing beach chair position. So we're going to go through this very fast because we have limited time. Patient is a 62-year-old male, 92 kilos, ASA2, presenting for a right shoulder arthroscopy with rotator cuff repair. Past medical history of well-controlled hypertension, hyperlipidemia, and a former smoker. Pre-op vitals are blood pressure of 138/82, heart rate 72, SpO2 98% on room air. For pre-op considerations, this patient's going to get an interscalene block to help with pain control post-operatively. One of the things to be aware of with an interscalene block is the risk of a unilateral phrenic nerve paralysis. This will present as patient having shortness of breath, respiratory rate changes, and pulse ox changes. Intraoperative care. This will be a general anesthetic with ET tube. I know there's some people that do it with LMAs. I do not. Standard monitors with the non-invasive blood pressure cuff on the non-operative arm. Standard induction meds. Patient will be placed in beach chair. It is our responsibility to make sure the head is secure and remains in neutral alignment. For maintenance, patient's going to be placed on sevoflurane. Make sure to keep end-tidal CO2 between 35 and 45. We want to be sure not to hyperventilate this patient because hyperventilation can cause hypocapnia, which then causes cerebral vasoconstriction, decreases blood flow to the brain. Hemodynamically, we want to make sure to keep our MAPs greater than 70. So for a case incident that could happen, shortly after position change, your MAP drops to below 60, but your heart rate is stable at 65. Teaching point here, in beach chair position, cerebral perfusion pressure is lower than the measure in the blood pressure cuff on the arm. This is due to a hydrostatic gradient, which makes a 15 to 25 millimeters of mercury difference between the arm blood pressure and cerebral blood pressure. Interventions you would do for this, you can reduce your volatile concentration, treat with phenylephrine bolus, and I would just get a drip ready. Key anesthetic concerns in beach chair. Cerebral hypoperfusion, which we've already covered. A potential for a venous air embolism. This is rare, but a potential risk due to the surgical site being above the heart. What to watch out for this would be sudden decreases in your end-tidal CO2, hypotension, and that mill wheel murmur. Hypotension and bradycardia related to Bujold-Jaros reflex. I don't know if I say that right, but you guys know what I'm talking about. This is often triggered by an upright position, which causes a decreased venous return. Just to go over that Bujold-Jaros reflex point by point. The trigger is an underfilled ventricle from decreased venous return, causing the ventricle to forcefully contract on itself, which activates the stretch chemoreceptors in the left ventricle. This sends afferent signals up the vagus nerve to the brainstem, and your response is increased parasympathetic tone, leading to a slow SA node firing, thus bradycardia. Also, from the reduced sympathetic tone, this leads to vasodilation and hypotension. Airway access limitations is also something to keep in mind. Due to the head fixation